Hello, and welcome to the Sleep Science Podcast. I'm Penny Lewis, a neuroscientist specializing in sleep and memory, and the presenter of this show. In the podcast, we talk about all things related to sleep, from dreaming and sleepwalking to what sleep does to our brain and our body, and how we can get more out of our sleep. Please see the podcast webpage for details. My guest today is Colin Espie, Professor of Sleep Medicine at the University of Oxford. Colin is a leading expert in insomnia and is also Clinical Director of the Experimental and Clinical Sleep Medicine Programme at Oxford. We begin by talking about insomnia and sleep problems. Professor Espie uses a multidisciplinary approach to explain that different strategies need to be applied to treat different sleep issues. He goes on to talk about Sleepio, an online platform which he's developed to help insomnia sufferers using cognitive behavioural therapy. Finally, he stresses the importance of evidence-based treatment for insomnia. For those who want more information after listening to the podcast, Professor Espie has a new edition of his book, Overcoming Insomnia, a self-help guide using cognitive behavioural techniques, coming out in September. See the episode webpage for details. I hope you'll enjoy our conversation. A lot of your work has focused on insomnia, and so can I just ask you to explain what insomnia actually is?
Insomnia is something that I think everyone has experienced from time to time. That really troubling challenge to get to sleep, or if you're waking up, that difficulty getting back to sleep again, and then waking feeling unrefreshed and feeling I've not been able to be as effective, as efficient on the ball as I would normally be because of my sleep last night. Now, everyone's experienced that from time to time, but with insomnia, we have a difficulty that's occurring 3 or more nights per week for at least 3 months. And in many cases, the people we see, it's been on for years and years and years. It's something that wears you down.
And are some people more likely to experience insomnia than others?
Well, that's a great question to think about the risk of developing insomnia. It's associated really, I think, with how we deal with stressors in our lives and also how resilient we are as individuals. So if you get somebody who is a little bit more vulnerable, perhaps because they've been unwell or something like that, they're more likely to be in a position to develop insomnia in a triggering situation, in a stressor. Where if somebody has been keeping really good health and very robust, it might take a bigger stressor to get them to develop insomnia in the first place. But what's really interested me in my career has been how does this problem that I think most of us could understand that in an acute situation you might not sleep very well. I've been interested in why is it that some people go on to develop a chronic problem that doesn't resolve itself. And I think that's where it gets really interesting because it seems that for some people, they develop really a great difficulty in sleeping, paradoxically, because they're so desperate to sleep.
And so it's this kind of a psychological circuit there, negative feedback loop of some kind.
A psychological circuit's a really good way to put it. I mean, if we think about what is sleep and how is it regulated, it's clearly not something that's a lifestyle phenomenon. It's not something that's a psychological thing. Sleep is very much a biological property, and it's there not just of human beings, but of all mammals, and most of the animal kingdom have sleep-wake cycles. So it's clearly not a fickle thing that is just there dependent upon your mood. But because it is such a driven biological phenomenon, it's actually quite vulnerable to psychology, because good sleepers aren't good at sleeping, if you think of it like that. A good sleeper has not developed some kind of skill or expertise that enables them to do it extremely well. And often when you ask a good sleeper, how is it you manage to sleep? How are you doing this? And people with insomnia ask their friends that all the time. How do you get to sleep? And they just say, I don't know, I just go to sleep. And I think precisely that's very, very important. And a parallel here might be if you think about breathing. It's clearly something, it's a physiological process, it's not a psychological event. But we know that people, when they panic, when they get anxious, can get very caught up in that and feel that they can't breathe. And then that concern and anxiety about not being able to breathe well makes the problem worse. And I think insomnia is a bit like that this biological property of ourselves, of to sleep at night and to wake during the day, and for that just to happen automatically, can become dysregulated by people trying to over-control the process. And I have so much sympathy for people who do that, because it is a very frustrating thing when you can't sleep. But they also know that the more I think about this, the harder it gets.
So worrying about it just makes it worse, basically, is what you're saying.
Worrying about it makes it worse, but I think it's not just worrying about it, it's attempting to try and fix it. It can often make it worse. If some of the listeners might be golfers or something, you're determined to hit that ball straight down the middle. And the harder you try to be deliberate about it, the more likely are you to slice it or hook it. It's about relying on the kind of motor memory there to swing the golf club well and to hit the ball cleanly. And I think that's kind of what good sleepers are doing without thinking about it. They're just going to bed and falling asleep, and they're not over-involved in the process. Whereas I think sometimes people with insomnia are a bit like tightrope walkers. They approach bedtime like a performance, like really anxious that they don't get it wrong, they don't fall off, and what if this happens, what if that happens? And trying to perfect something and desperate to find a solution. And of course, it is important that they do find a solution. But my point really is that kind of focus on it is worry plus, if you like. It's the worry is the mental component, but the behavioural component is trying to fine tune exactly what you do so it'll work. And that seems to be something that makes it more likely to fall off that tightrope. Whereas good sleepers are not walking a tightrope; they don't even think about it.
They just do it. Yeah.
It just happens. It just kind of falls into place, and I think that seems very, very important. And it's one of the reasons that a lot of my work has been focused on developing interventions for insomnia, cognitive behavioural therapy being internationally recognised as the treatment of choice for chronic insomnia. And you might wonder, well, why does a psychological approach work with insomnia? Because sleep is a biological thing, surely. So why are you using psychological language and techniques? Well, it's precisely because what we're trying to do is eliminate this kind of unhelpful psychology and replace it with behavioural habit, if you like, in such a way that it becomes automatic again, and that people can relearn, if you like, to sleep just like they walk and they talk without thinking about it.
So before we jump into the behavioral intervention, which we definitely will do, my understanding from looking over some of your many, many publications on this is that insomnia is linked to things like depression. It can be linked to psychotic experiences. It influences social interactions as well as quality of life. Can you talk a little bit about some of those links?
Yes, I think historically insomnia was seen as a bit of a symptom of something else. You're not sleeping, or that must be because you're depressed. Or you're not sleeping, that's because you're anxious. Or that you're not sleeping, you must be in pain or something. Like sleep symptoms, insomnia symptoms are casualty symptoms of something, some other accident. Something else is wrong. I think what we found through research over the years that actually there's what we call a bidirectional relationship between sleep and mental health. When we become unwell mentally, we do sleep less well. But also, if we're not sleeping well, we're at risk for developing mental health difficulties. And we've seen this in experimental studies that are done in sleep laboratories, perhaps a bit less now than used to be done historically, for ethical reasons. But we do know that if you systematically deprive people of sleep, or you systematically interrupt or fragment their sleep, that has knock-on effects. It's not just a bad experience, and I'm glad that's over, but I feel fine now that I can go on with my day. There are consequences of having that disrupted sleep at night. And those consequences are partly on our mood and partly on our cognitive functions, if you like, our ability to interact with our world and make sense of it, pay attention, and behavioural effects too. We know, for example, that a child who hasn't slept very well becomes sometimes quite hyperactive or impulsive. So these are the consequences of disrupted sleep at night. And these are the kinds of consequences we see in insomnia as well. As you say, it also affects our social lives, our relationships. In fact, clinically, very often when people come along to discuss their insomnia difficulty and you ask them, what brought you along today? They say, well, I've had this problem for 5 years. So you repeat the question, so why now? I say, my wife, my partner, my friend, whatever is saying, you need to get some help with this problem, because it's affecting not just you, but other people, and they can see it and feel it in the relationship and in your behavior.
So it's quite a broad impact like that. And what kind of proportion of people in our society actually suffer from this?
Well, when one uses rather conservative clinical diagnostic criteria, that is people that you would diagnose with a problem, we're talking about somewhere around 10 to 12% of the adult population qualifies having an insomnia disorder. But of course, many, many more are not sleeping well. It's a bit like depression. In order to say, well, you've got a depression, you've actually got a depressive illness, you would need to meet a clinical diagnostic criteria. But there are many more people than that who are feeling rather sad or low, are not at their best. So I tend to think of it as somewhere around 10 to 12%, and then probably about around double that would have significant symptoms of not sleeping well, but not qualify for having an insomnia disorder. But it's still an awful lot of people, 10 to 12% of the population. And probably overrepresented in that group are women and older people from midlife onwards. There's more vulnerability to developing insomnia as sleep kind of naturally fragments with age. And also in association with other developmental events, like the menopause, for example, which already are causing some difficulties for people's sleep. And then they're compounded when people become anxious and concerned about the inability to sleep.
So it's a huge percentage. And are there different models of what might be happening in insomnia?
Yes, the most dominant kind of model of insomnia historically has been a hyperarousal theory, and that is that people's brain state is hyperaroused relative to the good sleeping brain. And, there's a number of sources of evidence for that. And there have been studies, for example, conducted using PET scans, looking at brain metabolism and showing that in people with insomnia, even when they're asleep, their brain is relatively hyper-metabolized compared with good sleepers.
What does that mean exactly, hyper-metabolized?
Well, it means that the brain is processing more information. The signs are that it's processing more information in the way that a brain would when it's more awake than when it's more at rest. So the way they do these studies is they compare the PET scan images of good sleepers with people with insomnia, and you get then a picture of the net difference. And what you see in that picture is that the areas that are more active during sleep are represented in some kind of colour or highlighted in some kind of way, so you can see this is the difference between these two brain states. Another example of this might be if we looked at normal good sleep, we would see that during dreaming sleep, for example, the brain appears to be more active than quiescent than it is during non-REM sleep. And these are different types of sleep stages. We differentiate them partly because of this activated brain. Now, there's some evidence that this is what's happening in insomnia. And there's evidence also from other types of studies using quantitative measurement of the EEG, which is surface electrode measurement of electrical activity in the brain, suggesting that during sleep, and particularly during early sleep, people with insomnia have relatively more activated brains than people who are good sleepers. So there's different sources of evidence, suggesting this might be the case. Now, I suppose my approach to this is thinking, well, do you need to be hyper-aroused in order to remain awake, or just need to fail to decrease your arousal level? I mean, good sleepers fall asleep and there's a decrement in arousal and they fall asleep. So to my mind, the logic would be that if you're unable to get to sleep, or unable to get back to sleep, it's just that you don't have a dip in your arousal level sufficient to get you to sleep. You don't need to be hyper-aroused. You don't need to be supranormal. You just need to remain at the wake level. So I suspect that what we see in these studies, which are usually relatively small sample studies using PET scans or using quantitative EEG, is we probably get a mix of individuals, some of whom are probably at a trait level hyper-aroused, maybe 24 hours a day, that their brain level is more active, and they're actually more vulnerable to developing insomnia because they find it difficult to downregulate arousal anyway, and they're at a higher set point. There's a mix of people like that and others who probably aren't like that, but who in more of a conditioned way become aroused or find it difficult to downregulate arousal in bed because they can't sleep. A more situation-specific problem. And I think that's one of the challenges in research is how do we separate out these potential subtypes of insomnia? Because it's kind of a heterogeneous condition where people have the same end symptoms but may arrive there for somewhat different reasons.
So let me see if I understood. So what you're saying is there's this model that is about hyperarousal that says, because these brain scans show that many people who suffer from insomnia have this characteristic pattern of overactive brain areas. And so people have argued their brains are just overactive and it's much harder for them to switch off and go to sleep. But you don't necessarily agree with that model. And instead you think that the population of people with insomnia may be heterogeneous. And it may be that some people have this hyperarousal naturally and that may or may not interact with their insomnia or cause their insomnia.
But certainly other people have insomnia who do not have hyperarousal. And it's just that they have a normal level of brain activity, but they have trouble disengaging and going to sleep.
Yes, and I suppose an extension of that is that arousal, the activation or failure to de-arouse, it is actually kind of conditioned to the bedtime routine and to the environment of being in bed. So it is somewhat more situation specific. And one sees this in people with insomnia becoming anxious before they go to bed, wondering, thinking, what if I don't sleep tonight? Am I going to sleep tonight? I didn't sleep well last night. I need to sleep well tonight. I've got a busy day tomorrow. So they're approaching sleep in a somewhat different way from the beginning. You hear people talk about feeling very, very sleepy, feel they could just fall asleep. But then once they get into bed, they just now awake. And I think this is kind of similar to what we see in children, trying to get them into that settling routine. And what we're trying to do is not help our infant child fall asleep. We're not trying to put them to bed asleep. We're trying to enable them to feel content while awake in that environment and to be able to fall asleep naturally because they're not restless, anxious, or upset. And they're able to downregulate their arousal level and fall asleep naturally. I think there are people with insomnia who are kind of rather like that anxious child. Here's something so fundamental, I don't seem to be able to do it. And of course, I'm an adult, I should be able to do this. And people feel very frustrated. And so I think there are people who, are constitutionally somewhat have a high set point and they find it difficult to downregulate arousal at all times. But there are other people for whom the situation is much, much more specific. And it seems to be associated with bed itself and the bedroom environment. But I think the hyperarousal theory is just one of several theories. When I mentioned that I think the insomnia is an end state that arising from a number of different origins, I think arousal or hyperarousal is just one of those. I think there's other contributory factors as well. We can talk about some of those if you wish to, because I think in any subgroup of people with insomnia, probably individuals who conform to different types.
Yeah, would you mind briefly talking about some of those other models?
Yes. So, I think some people can't get to sleep easily because of the timing of their bedtime behavior. We know that sleep's regulated by a homeostatic drive for sleep, which builds up, across a period of sleep deprivation, which we call the daytime. But, there's another force at work here, and this is the biological clock, the circadian timing system, which resists, if you like, progressive sleepiness during the day. As we remain awake, broadly speaking, we remain alert. And then the circadian gate opens at night and we fall asleep. Now, for some people, that gating system is earlier, and for some people it's later. So if you're a bit of a night owl, the circadian gate, the opportunity to sleep, your natural sleep timing, doesn't occur till late. You might not be likely to fall asleep until, say, 1 a.m. or something, 2 a.m. But if you've got insomnia and you're struggling to sleep, you're not getting enough sleep, your instinct is often to get to bed early to try and catch up in your sleep. So you're not likely to fall asleep at a time when you're not kind of ready to sleep from what we call a chronotype perspective. So I think that there's an interplay between sleep factors and circadian or timing factors, the amount of sleep we need and when ideally we would have that sleep. And I think that's often missed out in the treatment of insomnia. And it's been focused too much on how do we manage people's arousal level. I think for some people it's a mix of these two things as well. They're not able to fall asleep because of trying too hard, but also because it's not the right time for them to fall asleep. And this is one of the reasons that some of the behavioural interventions that we use in treatment work quite well, because they combine both, sleep factors, if you like, and arousal factors and timing factors in the management of them. And often these are the kinds of approaches that people haven't tried because they're quite counterintuitive to them. So instead of spending more time in bed in order to catch up and be a good student of sleep and discipline yourself to try and get lots of sleep, which is what people with insomnia often do, sleep restriction therapy, which is a component of cognitive behavioural therapy, encourages people to go to bed for short periods of time to relearn to sleep through a shorter night. And by doing that, you quickly discover it's a struggle to stay awake. So instead of this attempt to fall asleep, they're struggling to remain awake. So I think the psychological approaches are very helpful at harmonizing, if you like, the circadian rhythm as the gateway into sleep and out of sleep into wakefulness. And also they're good priming the homeostat, the drive function for sleep. And if people ask me, which I sometimes do, what is the effective ingredient of cognitive behavioural therapy, I usually say to them, the effective ingredient is sleep. It's sleep itself that delivers sleep. It's the drive for sleep and the timing of sleep. And it's to find a way of rediscovering that that's crucial. So hyperarousal is one aspect, difficulty downregulating arousal is another. The timing of your sleep-wake pattern and discovering when is the optimal time for you to sleep is very important. And that behavioural aspect of trial and error, experimenting with shorter periods of sleep to see what fits is really, really important too. I mean, one of the anecdotes I often give people is to think of figuring out their sleep pattern a bit like figuring out what size of shoe you need to wear, and say, well, how do you know what shoe size fits you? People say, well, you try them on. That's how you find out how much sleep you need. You try different sizes and shapes and fittings, and then you find the sleep pattern that actually works best for you. But when you've got insomnia, you become quite rigid. You're kind of anxious not to change anything because although it's bad, you really fear it's going to get worse. And then you find some information that says, I'm meant to be getting 8 hours or 7 hours, and you think, that's what I should be trying to get. That doesn't make any more sense than trying to fit everyone, the whole population, into the same size of shoe.
It's a kind of scarcity mentality where you don't have enough and you don't want to lose more. It's a beautiful analogy with the shoe sizes.
Yeah, I think it's a helpful way to think about it. We want to think of sleep as a fundamental characteristic of us as human beings, but it's a fundamental characteristic of our individuality as well. And like any other biological phenomenon, it's expressed somewhat differently across individuals. It's the same thing, but it's not identical in everybody. And we seem to recognize that people are different body shapes, sizes, shoe size, hair color. We recognize all these individual differences and we cherish that. We think that's a useful thing. The idea of standardizing human beings is seen as anathema to most people. We're not interested in sleep eugenics, right? Making everyone the same. What we're interested in is discovering how much sleep you need. And I think people need to consider, how do we learn most things in our lives? We learn most things in our lives through trial and error. We go to school and we learn stuff and we're taught stuff, but actually most of the fundamental things we learn to do, particularly the things that are actually biologically primed, we have capability to do them because we're born with it, but we figure it out through trial and error.
Yes.
That's how we learn to walk, right?
Yes, and that's how we learn most things. Feels like we're segueing now into how we can treat insomnia problems. And it sounds very much as though what you're saying is there's an element of trial and error, but it's very structured trial and error around these concepts that you have introduced. So the circadian rhythm, as well as, possibly the ability to switch off, as well as the anxiety around it. So can we dive more deeply into that now? Can you talk about what we can do to help people sleep?
Yeah, so I think one of the first things I suggest to people is that we have a model of what normal good sleep should look like. And so therefore, where do we want to end up once we've solved your insomnia problem? We want you to be able to sleep with careless abandon, like the good sleeper. They don't overthink it, right? So the whole idea of how we approach this is not to do with closing in on sleep and locking off every corner of sleep and cornering the phenomenon and becoming so rigid there's no flex left. I think well-adjusted neurobiological systems have a lot of plasticity in them. They're able to adjust to circumstance. They're not so vulnerable. They recover quickly. So we want the individual to get to a position that they can become a good sleeper again, and that really involves not over-engineering it, not overthinking it. And the paradox is, of course, using psychological approaches to do that. And that's the evidence-based approach. Cognitive behavioural therapy is the evidence-based approach to treat chronic insomnia, and it can feel paradoxical to people that you're then saying, okay, so let's think about how you think about your sleep and let's look at what you do. So therefore, it's really important that we start off recognizing that this is a means to an end to be able to get to the point you can become a good sleeper again, who's somebody who sleeps without thinking about it. Now, CBT, I talked earlier about, we can think of, sleep in a very rigid way, like I need 7 hours, I need 8 hours, or sleep is a thing. Sleep's actually a very complex set of stages and phases. CBT is not a thing either. It's not the one thing. So I encourage people to think about CBT as having loads of different treatment options within it. Cognitive behavioural therapy is a bit more like pharmacotherapy. Pharmacotherapy is an approach to treating things using medicine. So if you said, you went home at night and said, I went to the doctor today and the doctor gave me pharmacotherapy for my whatever, you would be none the wiser, really. Well, what did he give you or she give you? Because all you really get sense that you got some kind of medicine. And the same is true with CBT, because there's so many different types of psychological medicines within CBT that I think the right way to think about this is what is the best component of cognitive behavioural therapeutics, if you like, that's going to help this individual. And for some people, that might be a more cognitive approach. It might be around managing their thoughts, and that's the thing that is keeping them awake. It might be about managing the way they try to force sleep, their effort to sleep and their frustration about not being able to sleep. That might be the key thing they work on. For other people, it might be around the timing of their sleep. For other people, it might be around finding ways to increase the pressure of sleep because they're spending far too long in bed. Just to give an example there, sometimes people say, I'm only managing to sleep 5.5 hours at best. And you say, well, how long do you spend in bed? And they say, I've given myself loads of opportunity to sleep. I'm always in bed for 7 or 8 hours. And I never get more than 5. In a situation like that, I would tend to go to a more behavioural approach and say, when you increase your sleep pressure, what's the chances of you sleeping 7 hours tonight? When was the last time you slept 7 hours or 8 hours? And they say, and they sometimes remember it. They think it was 3 summers ago, or something. And so they're set up for failure every single night. So in that situation, we take a more behavioural approach. In other situations, we might look at, for example, their conditioned reactions they have to be in bed, the bedroom environment. We might just simply say that you need to stop spending so much time lying awake in bed and need to get up and break the habit of this connection between bed and wakefulness has become a conditioned one. That would be a bit like similar to you find with people who get phobias, that they've got a reaction to the situation, like a dog or whatever. And other people love dogs and they'd love to love dogs. They'd love to love their bed and they want their bed, but they actually get anxious when they lie awake. And the best thing they can do is to break the habit of lying awake in bed. So this approach that I'm saying of picking the right piece of the CBT toolkit, the right therapeutic, is what we call formulation in psychological therapy. What's our best understanding of why you have got this insomnia problem? What's our best hypothesis about the approach that might be most effective? If we're correct about the hypothesis, then this would be the thing to pick. So let's try that. And CBT is a very collaborative approach. It's about sharing that formulation, it's about discussing that possibility and then putting it to the test to see if it actually proves to be correct in practice, that if we did X, we should get this Y result. And if we don't, then we can look at our theory again and we can approach it differently. So that's the way that one would approach the problem of insomnia using the CBT toolkit, rather than as a blunt instrument of here's a bag of lots of different things to do, things to help you relax, things to help you manage your mind, things to do differently, except and do all these things. And that can be very overwhelming for people. It also leads to a rather skin-deep implementation of the techniques. And that's not going to make a difference. I've tried that and it didn't work. So I tried that and it didn't work. It's really important to implement some changes in a meaningful way, focus 1 or 2 things, implement them consistently over a couple of weeks. And that's when we really know if that's going to make any difference or not.
And so it's a very individual approach. So you really have to get a lot of information about the person who has the insomnia in order to decide which aspects of the toolkit they are going to use.
Yes, I think the ideal approach is a very individualized approach, but it's a much simpler approach in some ways because it doesn't involve having to learn or do absolutely everything. It's more about being selective and then focused on trying that. And I think people generally prefer that approach. The challenges, of course, that people have in getting access to CBT is the main difficulty that there is, because if we look at England, I think the NHS prescription rate for sleeping pills is something like 14 million prescriptions per annum for sleeping pills. And then on top of that, maybe the same again of drugs that are given what's called off-label. That is, drugs that are not actually designed for sleep, but have a sedative side effect, so we give them those instead. So you can be talking about 20, 30 million prescriptions being issued. That in practice is how insomnia is being addressed. And that is not clinical guideline treatment, the clinical guideline treatment, would be to use a CBT approach. And I think what sometimes happens is that doctors and health professionals recognize I shouldn't be just providing medication, I should be offering something else instead. So they get some very condensed form of CBT, or it might simply be, here's a leaflet with some ideas on it. And it might contain some good, sensible ideas, but they're not going to be therapeutic for the individual. If you did the same for depression, for example, take a CBT approach, which again is an evidence-based approach, and said to people, I think that the problem is you're thinking very negatively. Why don't you try and think more positively? You say, yeah, but that's not really going to be therapeutic, right?
Sure.
So you can do this, you can do CBT kind of in the spirit of CBT, but it's actually not, it's not delivering therapy, because you need to be able to take treatment home and implement it in your life to make a real difference. You need help with that.
So you've developed Sleepio, which is this fantastic online tool which allows people to really undergo individualized therapy in their own home. Can you tell us a bit about that?
Yes. Yeah. We developed Sleepio about 10 years ago, really born out of, frustration on my part that we hadn't been successful in getting psychological help. I mean, we knew 10, 20 years ago that CBT was effective for insomnia. I did my first clinical trial, or published my first clinical trial, a randomized placebo-controlled trial of behavioural intervention for insomnia. I published it in 1989. So we've known a lot for a long, long time that psychological approaches are effective. The challenge has always been, how do you get them out to people? And up until 10 years or so ago, I'd been training a lot of people, and I still do, train a lot of people as clinicians and therapists. And we'd published 3 very large controlled trials where we train nurses in general practice or in hospital settings to deliver CBT to groups of patients to try and get CBT as an evidence-based intervention out at greater scale. But it's still scratching the surface, because the most immediate way of offering help is here, just take a pill. Now, I should say I'm not against medication, but I am for evidence-based practice. And here we have a challenge, because that evidence base for CBT is there, but it's not scalable. It's not something you can provide at the level it's required for 10 or 12% of the population. So we set about developing a digital intervention that's fully automated as a way of trying to deliver something, because it's software driven, could be as scalable as drugs. If you think about molecule drugs, you think algorithm software. That was the kind of approach that we took. And in order to do that, we set up a company that would develop that technology. And my main input to that was the content, if you like, of what we would deliver through CBT or through Sleepio as it became known. The governance around it, in terms of, this is not an app, this is a treatment. This is an intervention, it's got to work. And that brings on to the third thing was the research evidence. So we actually developed a placebo version of the program at the same time as we developed the real version of the program, and we conducted and published a placebo-controlled trial of Sleepio in 2012. And since then, there have been 12 randomized controlled trials published in various parts of the world using this intervention. It's now available, I'm pleased to say, in Scotland. It's available to the NHS staff in England through the NHS, and with increasing interest in Wales too. In the United States, the company's based in San Francisco. So we've grown this company up to try and scale up the whole enterprise. We now employ about 110 people. It's based in San Francisco. It's not something I ever thought I would do, to be honest, is get involved in developing a company. But I did it really because it felt like it was the only way to try and create something that would actually have these dual properties of being effective at a clinical level and being effective as a piece of technology.
No, I think that's a fantastic kind of combination. And obviously it's worked because, as you said, it's being picked up, overseas as well, and certainly in the UK. Can you just, for the listener who has never seen Sleepio, can you just explain what happens if you register there, or if you want to use Sleepio? What's the process you would go through? What kind of questions would you be asked, and what kind of treatment would it administer to you?
So Sleepio is delivered by a character who's called the Prof, right?
That's you, I guess.
Well, it's not actually. There's it's voiced by a professional voice artist. He happens to have a Scottish accent, but it's not. People think, was that you? And I'll be honest with you, I tried. I thought, oh, this is a piece of cake. I can do this voiceover stuff, and it was terrible. And it was terrible for precisely the reason that people don't sleep well when they try to, right? Because I was trying to be natural, and I just couldn't do it. You don't sound natural when you try to be natural. So it's delivered by the prof. He's an animated character, and his narcoleptic dog called Pavlov, he's a wee kind of side character. So what the prof does is he greets you, he welcomes you into the program. He says, let's get going by getting some assessment so I can understand your sleep difficulties, takes you through filling in some questionnaires and so on. But unlike, I think, lots of programs, you begin to get some benefit early on. I think one of the things that people struggle with is, I've got to spend half an hour filling in forms before anything really happens. And what we wanted to have up front was more of a sense of engagement with this virtual therapist. So that kind of gathering information from you kind of carries on over the course of the first couple of sessions. It's not just in the first intensive period of time. And the program is delivered over 6 weekly sessions. And you make appointments with the prof to attend his clinic. And of course, he doesn't exist, I'm sorry to say. He's a virtual character. But it's quite funny because you make an appointment and that goes in your diary and think you've made an appointment to go to do your next session, and all you're doing is going online and following the program or going on the app. But sometimes people can't make, something crops up and they drop the prof an email. I'm really sorry. I'm really sorry, but my mother's coming round for tea, or so. Can we change the appointment? So it's a bit like any of these virtual things. People buy into it, and it feels very real once you're involved with it, even though you're interacting with a virtual character. And if you went on the program in the middle of the night, for example, because the prof or the system knows your usual bedtime routine, the time that was planned to go to bed, the time that was planned to get up, say that the prof had advised you, don't lie awake in bed. If you can't sleep, just get up, it's fine. Whatever, depending on the advice that had been given. But if you went on to the program in the middle of the night, he would appear in his dressing gown with his nightcap on, and he would call you, he'd say, Penny, hey, Penny, I'm sorry you're not sleeping so well tonight. And to get this right took a bit of time. We didn't want to make it spooky, but actually people find it very reassuring because there's real-time help, And I think one of the challenges there is in traditional psychotherapy, in traditional medical practice indeed, is that it's like a commissioning approach, that you go and see someone who imparts knowledge, empathy and knowledge to you and advice on what to do, and you go away charged to remember this and to carry yourself through the next week or fortnight till you've got a chance to feedback how you get on, but you've no help in the meantime because the therapy was all in that room in the hospital or in the clinic. So this is a big difference, that as well as the potential to make an evidence-based approach scalable, so a GP anywhere in the country could say, do you want a pill or do you want to use this program? You can do either immediately. As well as that scalability, it also takes therapeutic a step forward, I think, because it gives real-time support and interaction. And so therefore, when you fill in your diary information or when you complete a task, or where you want to meet the prof again for some reason, he's there. So you've got that more immediate kind of reinforcement of things or source of help, which you wouldn't normally have. So I hope that gives a little bit of flavour. The content of the 6 sessions covers the cognitive and behavioural techniques, of which there are many. And as I said earlier, CBT is like a compendium of resources, and these are available to you. They're offered to you kind of selectively based upon your presentation, with some aspects of the cognitive work. For example, there are probably somewhere around 1 million combinations of what could happen. If you think about interacting with a games console kind of thing, you never play FIFA 2020, the same game twice, because the system's responding to you and what you're doing. Now, our system is not quite as intelligent as that yet, but it shows the potential of a digital approach to create a very engaging but essentially simple experience. And I think that's the key to it, because in the end, we want people to implement some things in their lives to make a difference so they get a better outcome. It's not just about having a nice experience. It's actually about changing this. And in the end, forgetting about it. And we were trying to cure the problem, trying to solve the problem, right? I mean, good sleepers sleep well. The problem is solved. That's the idea. We want to get people back to being good sleepers.
And how successful is the program at getting people back to being good sleepers? And, how long does that impact last?
Yes. So the studies we've conducted on Sleepio indicate that clinical outcomes are just as good as you would get from in-person therapy, and that they're enduring. So we published a paper in the journal JAMA Psychiatry into the early 2019, and that was a large randomized control trial of 1,770 people. And then we published a 12-month follow-up paper in the Journal of Sleep Research, I think it was, just with the 12-month outcome data from that trial. That's just one example of 12 studies, but what that study shows is a long-term maintenance effects, but also shows the generalized benefit. Because you might say, well, you've improved your sleep. Well, so what, right? Because when we spoke earlier about what insomnia is, it was clear insomnia is a bit more like a problem that's affecting you on a 24-hour basis, because you get difficulty sleeping at night. Then you've got knock-on effects of that during the day. So therefore, in order to get a good outcome, you really need to not just improve sleep or demonstrate that sleep can be improved, or that people are happier with their sleep or something. You need to demonstrate that their associated symptoms have improved as well. So for example, mood, anxiety, productivity, and those things that together build towards quality of life. So that study looked also at these broader outcomes and showed that those improved as well. And, I think, to my mind, logically, it should, right? Because if we're right that the difficulty that people have in insomnia is not so much that their capability of sleep is broken. It's not like the sleep homostat is burst or circadian timer is damaged, right? It's just that it's not working optimally. It's offset, behaviorally. It's in the wrong place, or, threat signals, anxiety signals, keeping you awake. You can't relax because you're very tense, or you're overdoing it, overthinking it, or for all the reasons we've spoken about. The logic would be that if you're able to remove those impediments to sleep and to allow sleep drive, to populate, if you like, your sleep period at the right timing for you, then most people should be able to restore their sleep again. And if sleep is getting back into good shape, they should begin to feel the benefit. The effect sizes of using Sleepio to treat insomnia on depressive symptoms are similar to the effects of an antidepressant drug.
Wow.
Now, we're not actually treating people with depression at this stage, let me be clear. But the point is that sleep is of fundamental importance for emotion regulation. And it should be the case, from a science perspective, it should be the case that if insomnia is part of a prodromal depression, or insomnia is part of a risk for developing depression, it should be the case that if you treat insomnia effectively, it should reduce depressive symptoms or prevent them happening in the first place. What's breaking new ground is that, hey, we could treat insomnia at scale, and we could begin to deliver guideline care to the population.
And it could have long-lasting effects. I mean, you've talked about a follow-up, a 12-month follow-up. So that's, that's quite impressive. And you've also said that the outcomes are as good as antidepressants or sleeping pills.
Well, the outcomes for antidepressants and sleeping pills are terrible on sleep. The evidence is that you should only be giving sleeping pills for a few nights, and there's no real evidence that antidepressants are effective for insomnia, although they're commonly prescribed. I was saying the effects are similar to CBT when delivered in person.
Okay.
They're similar to that,
which is superior to the effects of the pills.
Yes, I mean all the clinical guidelines recommend CBT as a first line treatment. The British Association for Psychopharmacology guidelines were published a couple of years ago. The European Research Society guidelines similarly, and the American College of Physicians guidelines published a couple of years before that, all are saying that CBT should be the first treatment given for chronic insomnia, and they're saying that the medication should only be given if CBT is ineffective. But of course that is a bit of a pipe dream. So the mission here is really to find a way of delivering that care. And of course, logically, what one would do is when one would incorporate an intervention like Sleepio at scale across the population, and then you would use your clinicians and your therapists to deliver CBT if further help is needed. In other words, dealing perhaps with more complex cases who've got more comorbid difficulties or that kind of thing. So I think the logical way is to incorporate this digital medicine into a step care kind of approach to managing sleep at population level. It's not a solution for everyone in the sense that, some people may need more, and that's fine. But that's what happens at the moment. Your GP would manage most conditions and then would pass people on for further care if they needed it. It's just that the GP doesn't have anything at the moment in the CBT locker to be able to offer at the first line of care. So that's what's happening across the UK. People are now using Sleepio. We got funding from Innovate UK to do a big intervention implementation study in Oxfordshire, Buckinghamshire and Berkshire. So, that was done in collaboration with the NHS over a couple of years. And a report was written on that, including a health economic report, which showed that this was cost saving, that GPs liked this approach and were happy to use it. And now it's being rolled out into other health board areas, other health authorities, been picked up by NHS England to give to staff during lockdown, and is now being confirmed in a contract. I think it's a way forward, not just for Sleepio. I don't think we need an environment with a single product. I think what we need is to have a choice amongst evidence-based alternatives. That's what we respect in the NHS. That's what we expect we would get from a doctor. We wouldn't expect a doctor to say, go and look in the App Store and find something, or to come up with some idiosyncratic anecdotal recommendation. We'd expect the health service to direct us towards things that work and are effective and safe. And the more choices we have amongst therapeutics that are safe and effective, really the better for the health of the population. I think Sleepio is just in the vanguard and the pioneer core, really, where this is concerned.
So that actually brings me to the next question, is what do you see as the future of these kinds of sleep medicine, of these kind of applications? What are the next big steps that you think are going to be taken?
So I think what we'll see in the whole kind of area of apps and mental health interventions, I think we'll see clarification over the next few years. It's a bit of a wild west out there just now. We've pioneered an approach that is very traditional in the sense of sticking close to clinical integrity, staying close to clinical evidence. The truth is there's so much out there that has just been touted towards people. I think what we'll find is it will settle down to what we have at the moment in pills that everybody knows and the doctor knows these are pills that work and that you'll get in prescription, that are recommended, that have an evidence base, that the NHS will pay for, and these have a proper regulatory basis. And these other pills are things you can buy if you want. You can get them in the shops, or you can get them in a homeopathic store, or you can get them wherever. But they're not really evidence-based. They're more lifestyle products. And I think there's a lot of mental health apps, programs, and so on that have virtually no evidence and have no intention really of gathering evidence, except to foster a marketing claim. And that is disingenuous. I think we'll see the industry grow up and separate into the kind of over-the-counter industry, as it were, and the mainstream clinical industry. And that's what I hope will happen. I hope that will lead to more academics like myself taking an interest in this area and to hold industry feet to the fire in saying, this matters, evidence matters, and I hope we'll see the evolution of the methodologies that will be required to these kinds of interventions in the future. I mean, I think at the moment the approach to take is using the randomized control trial, the standard approach, in multiple randomized control trials, pre-registered with stated primary outcomes showing clinically meaningful differences, and then supported by real-world evidence thereafter. I think what we'll see over time is the evolution of new methodologies that will allow us to develop personalized digital interventions, finding ways of evaluating those as more like personal journeys. Because one challenge with a randomized control trial is it tends to see everyone as the same, and then you're randomized to conditions. So I think the personalised medicine approach that we're seeing taking place in medicine more broadly will come to bear on the digital medicine area, and we'll see the use of machine learning algorithms driving a lot of these things.
So I'm aware that I've taken a huge amount of your time, and I could ask you so many more questions, but I will restrain myself on this occasion.
No, well, thanks for taking this initiative. I mean, I think it's great to be doing these podcasts. I'm delighted to contribute, and I hope it sparks more debate and discussion. I've probably said some things that will provoke some thought, and maybe even some counter positions, and I think that's healthy and helpful. I mean, the more that we can, sleep is at the centre of our lives. literally at the centre of our lives in every way. And the more that we can do to help people just consider the importance of sleep in their lives, to try and improve their sleep and get help with the struggling, the better. For too long, it's been a bit of a Cinderella topic. And I think when you mentioned joining things up, I think, in terms of research efforts as well, that's something we should all be doing. We should be working more closely together, as well as thinking about how the technologies could all work well together. We should be galvanizing the academic and scientific efforts, and also the training level for our junior people, to give them opportunities to interact more. So it's been a pleasure.
Yeah, well, it's been a real pleasure for me. And I've learned a lot. I'm very grateful for your time, and also for just this kind of work that you're doing, because I think it's really important. So
thanks, Ben.
Thank you.
You've been listening to the Sleep Science Podcast with me, Penny Lewis. My guest today was Professor Colin Espie from the University of Oxford, and the producers were Bianca Stretter and Sophie Smith. For those who want more information after listening to the podcast, Professor Espie has a new edition of his book, Overcoming Insomnia, a self-help guide using cognitive behavioural techniques, coming out in September. See the episode webpage for details. If you've enjoyed this show, please consider subscribing to the podcast or liking us on Twitter. We're planning a Q&A session for the last episode of this series, so if you have questions about this episode or anything else related to sleep, please send them to us on Twitter at #SleepSciencePodcastQ&A, all one word. Thanks for listening, and until next time, sleep well.